Hello, Dental Team listeners. This is Kiera, and today is a really awesome and unique day. It is, I think, the second time I've had somebody in the podcast studio with me live for a podcast, and it's the one and only Jason Dent. Jace, how are you?
I'm doing well. Good morning. Thanks for having me.
It is crazy. I mean, I watch Instagram reels like this all the time where people are like in the podcast and they're hanging out on two chairs and couches, and now look at us. We're doing it. Cheers.
Cheers.
That was a mic cheer for those of you who are only listening. But yeah, Jace, how does this feel to be on the podcast?
It's weird. Like, I was not nervous at all talking about it. I got really nervous as soon as you hit play. So if I stumble over my words, please forgive me ahead of time.
Well, Jason, I appreciate you being on the podcast because marketing had asked me to do a topic about teledentistry. And I was like, oh, shoot, that's like not my forte at all. And so you and I were actually chatting in the hot tub. We call it think tank session. And you and I, we have a lot of good ideas that come from that think tank.
Yeah,
a lot
there's
of business.
no phones. That's why.
We do leave our phones out, but I was talking to Jason, and this is actually a podcast we had talked about quite a while ago. Jason has a lot of information on pharmacy. And if you don't know, Jason is a really, we were going through all of it last night as kind of a mock in the tub. And I think it's going to be great because I feel like this is an area working at Midwestern and knowing about how dentists, pharmacology was surely not your favorite one. Jason actually helps a lot of dentists with their clearances. And so we were talking about it, and I feel like it'll just be a really awesome podcast for you guys to brush up on pharmacology, different things from a pharmacist side. So Jason, welcome.
Well, thank you. Yeah, no, we were talking about it, and Kira's like, what should I talk about on the podcast next? I have all these different topics. And she's like, what do you know? And the only real interaction I have with dentists is doing clearances for procedures. We get them all the time, which makes sense. Lots of people are on blood thinner, so I've always told Kiera, I'm like, hey, I could talk about that. Like, that's kind of a passion of mine. I'm not a dentist, or my name is Jason Dent. So in Hebrew, Jason means tooth. No. Sorry. Woo! Nerves are getting to me. Jason means healer, and Dent means tooth. So my name means tooth healer. So Kira's a little upset. Can we just
talk about?
I brought that up before you could talk about it more. So my name means tooth healer, but I did not become a dentist. I know you wanted me to become a dentist.
I did.
I don't know why. I enjoy medicine. I know what you're going to get to already, the things you're going to ask me. There's been years of this. But nevertheless, that's my name. We'll get that out of the way.
But you did give me a great last name, so I mean it's okay. All is fair in love here.
SEO's up for that.
But yeah, Jason, I'm gonna get you right into the show, and I'm gonna be the host, and we're gonna welcome to the podcast show, Jace. How are you?
Good. So, but getting into clearances, right, is what you're kind of talking about.
You know, before we get to clearances, I actually wanted Jason, for the listeners who don't know who haven't talked to you, don't know, let's kind of just give them how did you go from Kiera wanted you to be a dentist to now, Jason, you are on the podcast talking as our expert on pharmacy.
Fantastic. I've always really loved medicine a ton. As a kid, getting headaches and taking Excedrin, you just feel like a miserable pile of crap, and then you take 2 pills and all of a sudden you feel better. That's amazing. How does that happen? Also getting earaches as a kid, just being in so much pain, and then taking some medicine and you start feeling a lot better. So I always had a lot of appreciation for that. I've always been mechanically inclined. Went to started doing my undergrad and took biology and learned about ATP synthase, which is a spinning enzyme that's inside the mitochondria, like a turbine engine. I used to work on small engines on my dirt bike and thought that is so cool. So I really got wrapped up into chemistry. That's all the mechanics of chemistry really pulled me in. I'm not getting goosebumps.
I was checking.
I usually get goosebumps when I think about chemistry. But it's so cool. You think an engine's awesome, like pistons and camshafts and pressures. The cell is the same thing. It's not as loud, so it's not as cool, but it's fascinating. So that's why I really like chemistry and really got into coagulation. So I did my residency after pharmacy school.
So we went to Arizona for 3 years. You did, and your main focus, you were never wanting to be the guy behind the counter.
No, I haven't done that. No, I love them though.
Clinical.
I've always really want to go clinical. But I love my retail pharmacists. They're amazing resources. And I use the retail pharmacist every day still to this day, but I went more the clinical route, really love the chemistry aspect of it. Did my doctorate degree, and then I did my residency in Reno. Reno's
That's how we got here, everybody. Yeah. Welcome to Reno.
Strategically placed because I was really interested in critical medicine, and where we're located, we cover a huge area. So we pull in to almost clear. We go clear to Utah, clear to California, all of northern Nevada. We get cases from all over. So we actually are kind of like the first hub of care for a lot of areas. So we really get an eclectic mixture of patients that come in that need all kinds of different cases that are coming to them. So it's what I really wanted. So I did my residency in critical care there. And then for the next 10 years, I worked in vascular medicine, with my final 5 years being the supervisor of the clinic, ran all the ins and outs of that. So my providers, 2 doctors were on our views. So when we talk about dentistry, talking about production, those kinds of things, totally get it. My doctors were the exact same way, my vascular providers. There's some pains there, right? You want to be seeing patients as much as possible, being able to help as many people, keeping the billing up. And had other nurse practitioners, had four practitioners, a fleet of MAs, 8 pharmacists. We also had that one location. We had, going off the top of my head, I think we had 8 locations running as well. So, and we took care of all different kinds of vascular cases that came to us. Most common was blood clots, which is an easier way of saying VTE. There's so many different ways to say a blood clot. Like you might hear patients say, I've had a PE or a DVT or a venous thromboembolism or a clot in my leg, right? They're all clots, but in different locations. Same with an MI, and MI can be a clot as well. So that there's a lot of, everybody's kind of saying the same thing, but sometimes the nomenclature can make it sound hard, but it really is actually pretty simple.
Yeah. No, and Jason, I love that you've been in, like, and even in your, when you were getting your doctorate, you were in the ER. Yep. You also worked in retail pharmacy. I remember you having a little sticker on your hand. And
retail pharmacy, I have a lot of respect for those guys. They have a lot of pressure on them.
And then you also, what was that test that you had to take that, I don't know, you were like studying forever for it?
Board certification for NABP. Yeah. So I did that board certification as well.
And now you've moved out of the hospital side onto another section in your career.
Now into insurance, right? So it's really, really interesting. So now I'm on the other side, reading notes and evaluating clinical appropriateness and trying to help patients with getting coverage and making those kinds of determinations. So yeah, I've really jumped all over. Really love my clinical days. I do miss them. But yeah, kind of had a good exposure to a lot of pharmacy, a lot of dentists actually, with all the clearances that come through.
Which, Jason, I really appreciate that. And honestly, I know you are my spouse, and so it's fun to have you on. But when I go into conversations like this, I don't know any of this information. And so finding experts, and Jason, I think, hears me talk more about dentistry and my business than I do hear about him on pharmacy. So as we were chatting about this, I really realized you are a wealth of knowledge because you've been on the clinical side. So you've done a lot of patient care, and you've seen how medications interact. And I know you've had a few scares in your career, and you've known some physicians that have had a few scares, and you've seen plenty of patients pass away working in the ER. And gosh, in Arizona, drownings were such a big deal. I remember when you were in the ER on your rotations, I'd be like, who died today? Like, tell me the stories. And you've really seen, and now going on to the insurance side, I felt like you could just be such a good wealth of knowledge, because I know dentists are sometimes so I would say, like, maybe just a little more anxious when it comes to medications. I know that dental students from Midwestern were like, here it was like 4 months and we had to like pass it, learn it. And Jason, you've done 4 years plus clinical residency, plus you've been in it. And something I really love about Nevada medicine is they've been so collaborative with you. Yeah. So like your your cardiologist, they diagnose and then they send to you to treat with medicine. And
yeah, I've been really lucky being here in Reno too. The cardiology team has been amazing to work with. We started a CHF program, congestive heart failure program for patients. So we would collaborate with the cardiologist. They'd see the cardiologist, and then they send them to the pharmacist to really manage all the medications. So there's pillars of therapy called guideline-directed medical therapy, and the pharmacist would take care of all that. So that's going to be your beta blockers, your ACEs, your ARBs, your Entresto, which would be a little bit better, spironolactone. So just making sure that all these things are dosed appropriately, really monitoring the heart, make sure that patients are getting better. And we've had real positive outcomes when sorry, this is a totally off topic.
Please do. So talk about that study.
When we looked at when patients were coming to see our pharmacists in our clinic that we started up, the patients were half as likely to be readmitted. And this was in 2018. And our pharmacists, we're thinking about all the medications. We're usually adjusting diabetes medications too at the same time, just kind of naturally just taking care of all their medications, because we kind of got a go ahead from the providers, a collaborative practice agreement, that we could make adjustments to certain medications within certain parameters. So we weren't going rogue or maverick, but we were definitely trying to optimize our medications as much as possible. And then years later, some studies came out with, I'm sure you've seen Jardiance and Farxiga. I don't get any kickback from them. I have no conflicts to share. But because our pharmacists were really optimizing that medication, those medications were later shown to reduce hospitalizations in heart failure, even though they're diabetes medications.
Fascinating.
So it wasn't really the pharmacist. It was just the pharmacist doing as much as they can with all the tools that were in front of them. And then we found out that the patients were going back to the hospital half as much as regular patients. So
That's incredible.
Being here, it's been so amazing to work with the providers here. Like
Yeah.
the providers here want to help patients, don't have an ego. I mean, it's awesome.
I love
So
it.
awesome.
I do love how much I think Jason sees me geek out about dentistry, and I love watching Jace geek about his pharmacy and how much he loves helping patients. And really, that was the whole idea of, all right, dentistry has pharmacy as a part of it. And I know a lot of dentists are sending in clearances. And I know working in chair side, it would be like, oh no, if they're on warfarin or on their blood clot, you guys, I honestly don't even know half of what I'm talking about because this is not my jam, which is why Jason's here. But I do know that it was always like, well, we got to talk with their provider.
Sure.
And so having Jason come in and just kind of explain, being the pharmacist that is approving or denying or saying yes or no to take them off the blood thinners in different parts, because you have seen several dental I don't know what they're called. What is it? Like clearances? Is that what comes to you? I don't even know. In my mind, it's like, here is the piece of paper that gets mailed to you as the pharmacist, and then you mail it back. So whatever that is. But Jace, let's talk about it, because I think you can give the dentist a lot of confidence coming from a pharmacist, what you guys see on that side. When do you actually need to approve or disapprove? Like, let's kind of dig into that.
Yeah. Well, first of all, I think I'm not a replacement for any kind of clinical judgment whatsoever, right? Every patient's different. But the American Diabetes Association, you can tell I work with diabetes a lot. American Dental Association has some really great guidelines on blood thinners, and I would always reference them. I actually looked at their website today. Make sure I'm up to speed before you get back on this again. They have resources all around making decisions for blood thinners. And I think the one real important thing, in putting myself in the shoes of a dentist or any kind of staff that's around a patient that's in a chair, if they say I'm on a blood thinner, right, a flag goes up. At least in my mind, that's what goes up. Like, okay, how do we get across this bridge? And I think the important thing to really distinct right then when they say they're on a blood thinner is that is kind of that's a slang word for a lot of different medications, right? Like, it's the overarching word that everybody pulls up saying, I'm on a blood thinner. It's like, okay, but I don't know what to say. It's like, I have a car. You're like, okay, do you have a Mazda? Do you have
a Toyota,
Jaguar?
Honda. What do you have?
Or even worse, it'd be like saying, I have a vehicle, right? So when somebody says they're on a blood thinner, it opens up a whole box of possibilities of what they're doing. Blood thinners are also, when they're taking these types of medication that are quote unquote a blood thinner, it doesn't actually thin the blood like adding water to the blood, if that makes sense, or like thinning paint or like thinning out a gravy, right? It doesn't do the same thing. Blood thinners, really what they're doing is they're working on the blood, which is really cool. I'll try not to tangent on that. When they're working on the blood, it's not thinning it per se, but it's making it so that the proteins or platelets that are in it can't stick together and make a clot quite as easy. So whenever somebody's on a blood thinner, I usually ask, what's the name of the blood thinner that you're on? It's not bad that they use that slang. That's okay. We're on the same page. But it's really broken into two different classes. There's anticoagulant and anti-platelet. And a way to kind of remember which is which, when residents would come through our clinics, the way that I teach them is a clot is like a brick wall. It's not always a brick wall. Usually blood isn't as a liquid going through, but once it receives some kind of chemical message, it starts making a brick wall with the mortar, which is the concrete between and the bricks, the two parts. When it's an anticoagulant, it's working on that mortar part. When it's an antiplatelet, it's working on the bricks part, right? You need both to make a strong clot or strong brick wall. But if you can make one of them not work, then obviously, like if your mortar is just water, it's not working, right? You're not going to make a strong brick wall. So totally. That's kind of the two deviants right there. So that's what I do in my mind real quickly to find out, because antiplatelets are usually, so that's going to be like your Plavix, Ticagrelor, Brilinta.
And hold on, antiplatelets are bricks? Or
good job, bricks.
They're the bricks. Yeah, and so the reason I was thinking you could remember this, because I'm...
Oh, yeah.
Antiplatelets, it's a plate, and a plate is more like a brick. An anticoagulant, I don't know why quag feels like mortar to me, like quag, like, it's like slushy in the blood, like it's coagulating. It's a little bit of that, like, honestly, I'm just thinking like coagulated blood is a little bit more mortar-ish.
Yeah.
And so platelet is your plate, like a brick, and antiquag is like the gooey between the bricks. Okay.
There's an
I
exception.
got it.
Yeah. So there's an exception to every rule, but when they're on an
Don't worry. This is Kiera, just like very basic. You guys are way smarter listening to this, and that's why Jason's here.
No, you helped me pass pharmacy school when we were doing all the top 200. You helped me memorize
I just know what Flexeril is. All right. That's a muscle relaxant. That's
Cyclo.
I don't know that part. It's a cyclo because you guys are cycling and flexing. I don't actually know. I just know it's a muscle relaxant. So that's about as far as I got.
When we're looking at anti-platelets, so that's the brick part. So it's going to be your, like ticagrelor, Brilinta, clopidogrel is the most common one. It's the cheapest one. So you probably see that one the most. Those, I mean, there's an exception to every rule, but that's generally being used after like a stent's placed in the heart. It can be used for VTE. There's some out there, but that's pretty rare. But also for some valves that are placed in hearts, they can be used for that as well. So anti-platelet, really thinking more like a cardiac event, right? Like I said, there's always an exception to every rule, but that's kind of where my mind goes real quickly because we're gathering information from the patient. If they're on an anticoagulant, those are like going to be the new ones that you see commercials for all the time. So Xarelto, Eliquis, those are the two big ones right now. They're replacing the older one.
This is, and also we were supposed to do a disclaimer of this is current as of today because the ADA guidelines do change.
They do.
So this will be current as of today. And Jason, as a pharmacist, is always looking up on that. I had no clue that you are that up to speed on like dental knowledge. And so just throwing it out there that if you happen to catch this podcast a few years back, that obviously check those guidelines. Absolutely. For sure.
But the new ones are the Xarelto and Eliquis. They're replacing the older ones of warfarin. Warfarin's been around for a really long time. We've seen that one. Those are anticoagulants. So when you're looking, when a patient says that, generally they're on that medication because they've possibly had a clot in the past or they have a heart condition called atrial fibrillation. Those are kind of the two big ones. Like I said, there's always caveats to it, but that's kind of where my mind goes real quickly. And then as far as getting patients cleared, there's the American Dental Association has really good resources on their website. You can look at those, and they're always refreshing that up. They even say in their own words that there's limited data around studying patients in the dental chair and with anticoagulants or antiplatelets. It's pretty limited. There's a few studies, some from 2015, some from 2018. There's one as recent as 2021, which is nice. But really, all of those studies come together, and it's really more of an expert consensus. And with that expert consensus, they have kind of simplified things for dentistry, which is really nice. And comparing that to, we have more data for like total hip replacement, total knee replacement. We have a lot of data, and we know really what we should be doing around then. But going back to dentistry, we don't have as much information. So they always say use clinical judgment, but they do give some really great expert guidance on that. So if a patient's on an anticoagulant, they generally recommend that it doesn't need to be stopped unless there's a high bleeding risk for a patient. So as a provider or as a clinician in the practice, you can be looking at high bleeding risk. Some things that make an oral procedure a little bit lower risk is one, it's in the compressible site, right? Like we can actually put pressure on that site. That's the number one way to stop bleeding is adding pressure. It's not like it's in the abdominal cavity where we can't get in and can't apply pressure. So number one, that kind of reduces the bleeding risk as number one. Two, we can add topical hemostatic agents. Dentists will know that better than me. There's a lot of topical ways to do that. So not only pressure, but there's those things as well. And also, but there are some procedures that are a little bit more likely to bleed. And that's where you and dentists would come in hand. Well, what's the word? An APO?
Oh, the APOectomy.
I got it right. Okay.
You did.
So I didn't
Good
do
job.
Too far, right?
Because didn't you tell me last night that the ADA guideline was like, what, 3 or 4 or more teeth?
Great question. 3. So you can extract 1 to 3 teeth is what their expert consensus
1 to
is,
3 teeth
without really managing or stopping anticoagulation or doing anything like that. I think that's some good guidance from them. I'm going to add a Jasonism on that though. So with warfarin, I do see why dentists would be a little bit more conservative or worried about stopping the warfarin, because warfarin isn't as stable as these newer agents. Fair. Warfarin, the levels, quote unquote levels, can go really high, they can go really low. And if the warfarin levels are high, they're more likely to bleed. So I do think it makes sense to have a really recent INR. That's how we measure what the warfarin's doing. Sure. I think that makes a lot of sense. But the ADA guidelines really go into the simplification version of all these blood thinners. You know, generally it's recommended to not stop them because the risk of stopping them outweighs the benefit of stopping them in almost every case. So when you're with that patient, right, they say, I'm on a blood thinner, finding out which kind of blood thinner that they're on. You find out that they're on Xarelto, right? How long have you been on Xarelto for? Oh, I've been on it for years. You don't know exactly why, but if they haven't had any recent bleeding, you're only going to remove one tooth. You can do what's called a has bled score. That kind of looks at the bleeding risk that they'd have. That'd be kind of going a notch above. But in my mind, removing one tooth isn't a real serious bleed risk.
Sure.
I love to hear from my dentist friends if they disagree, right? But ADA says 1 to 3 tooth removals. Extractions, that's the fancy word. Extractions,
yeah. So for extracting teeth out
is not really that invasive.
Sure.
It's not that high risk, so it's usually perfectly fine. So if a patient was on Xarelto, no other, this isn't a vacuum, right? I'm not looking at any other factors, which you should be looking at other factors. I would be perfectly fine to just remove 1 to 2 to 3 teeth.
And when those clearances come in, because dentists do send them, talk about what happens.
Yeah.
You guys were working in the hospital and you guys would get these clearances all the time.
We get them so often. I mean,
let's talk about what you guys do with the students.
4 or 5 a day. We'd love to give it to our students, student pharmacists, to ask them what to do. And they would usually look up the American Dental Association guidelines and come up with something. We're like, yep, that's what we say too. In fact, we say it so many times a day that we have a smart phrase which just blows in the information real quickly and faxes it right back to the provider.
So it's like a copy paste real quick. So what I wanted to point out when Jason told me this is dentists like hearing this and learning this can actually save you guys a ton of time to be able to be more confident, to not need to send those clearances on. And we were actually talking last night about how I think this might be a CYA for dentists.
Yeah.
But like, as we were talking, I think, Jason, you seeing so many other aspects of medicine, like you've literally seen patients die, you've seen other areas. And so coming from that clinical, like vantage point, we were realizing that like dentists, we are so blessed to live in I enjoy dentistry because like possibilities of someone dying, not super high, luckily in dentistry. The only time that I have actually had a doctor have a patient pass away, and it was only when they were completely sedated and doing some other things, but that was under the care of an anesthesiologist. And so that's really like our high risk. And so hearing this, Jason, that was one of the reasons I wanted him to come on, is to give you doctors more confidence of, do we have to always send to a pharmacist? And I mean, hearing that on the pharmacy side, they're just sending these back, and not to say to not CYA, to not cover this, because you might be questioning like, well, do I really need to? But you also were talking about some other ways of, so number one, you guys are just going to copy back the ADA guidelines. So check the ADA guidelines first.
And I think that gives a lot of confidence to a provider or a dentist, is that you can go to the ADA guidelines and read them, right? Like you're listening to some nasally monotone pharmacist on a podcast.
Rumor has it, people love him at the hospital. They were like, you're the voice on, he's been told he has a good radio voice.
For the clinic, I was the voice, like, you've reached the vascular clinic, right? And they're like, oh my gosh, you're the voice. But sorry, you got me distracted.
That'll be your next career, Jace. You're going to be a radio host. Yeah.
Oh,
okay.
I would love that. I love music. But you're hearing it from a nasally guy, but you can actually read the ADA guidelines. You just go right to the ADA, click on resources, and under resources, it has information around anticoagulants. I think that's the best way to get a lot of confidence about it, because they have dentists who are the experts making calls on these kinds of things. I'm just reiterating what they say. But I think it makes a lot of sense to help providers. And the reason why my heart goes out to you as well is having the providers that used to work underneath me. They're always looking for RVUs, which is a fancy way of making sure that they're drilling and filling. Can I say that?
Yeah,
right?
you
Like
can say drill and fill. That we're productive,
they're
right?
being productive, right? So they're always looking to make sure if a patient's canceling, like, get somebody in here. Like I need to be helping people all day long. That's how we keep the lights on. That's how I help as many people. And so if you have a patient coming in the chair and it has an issue, and they say I'm on Xarelto, well, you can ask real quickly, why are you on Xarelto? Oh, I had a clot 10 years ago. I'm like, oh my gosh. Well, yeah, we're pretty good to go then. I'm not worried. We're only removing one tooth, or we're just doing a cavity or a cleaning, something like that. Shouldn't be an issue whatsoever, because there's experts in the dental society, the ADA guidelines, that recommend 3 teeth or less, minimally invasive. They really recommend if it's going to be a really high bleeding risk. And clinically, that's where you would come in, or yourself.
Sure.
Apioectomy is one that's like on the fence line. I don't know where implants
though, and like we were talking, implants aren't usually like a day of procedure. Most people aren't popping in having tooth pain and we're like, oh, let's do an implant. Now sometimes that can be the case, but typically that one's going to have a few other pieces involved, and so that is where you can get a clearance if you want to. But we were really looking at this of like, so many dentists that I know that you've seen will just send in these clearances because they are. And I think maybe a way to help dentists have more confidence is, you guys, I love routines. I love to not have to remember things. So why don't we throw it in, have the team member set it up where every quarter we just double check the ADA guidelines. Are there any updates? Are there any other things that we need to do on that? That way you can just see like getting into the language of this, of what do I need to do? Because honestly, you guys, I know pharmacy was not a big portion for it. And so, recommending different parts, but I think this is such a space where you can have confidence. And there's a few other things I want to get to, and I know
I have some pearls too.
Okay, go. I'm ready.
Sorry. So once you get me in talking about drugs, I'm not going to stop. So some other things around that too is these newer blood thinners like Xarelto, Eliquis. They now have reversal agents. So a lot of providers in the past were really worried about bleeding because we can't turn it off. We can turn those off. Warfarin has reversal as well, right? So I'm looking at these patients. It's really low risk. It's in the mouth, generally speaking. Very rarely are they a high bleeding risk. Now, if you're doing maxillofacial surgery, this does not apply, right? Like this does not apply whatsoever.
This is where you're like general dentist, your pediatric dentist.
Yeah, and it's kind of on the fly. So just trying to really help you to be able to take care of those patients on the moment, have that confidence, look at the ADA guidelines, have that in front of you. I don't think it's a bad thing to ever check with their provider if you needed to, right? Like if you're thinking, I feel like I should just check with the provider, I would never take that away from you. But I just want to kind of steer towards those guidelines that are out there to help. But what did you want to share?
No, yeah, I love that. And I think there were just a few other nuggets that we were chatting about last night that can help dentists just kind of get things passed a little bit easier. So you were mentioning that if they were needing to talk to their like cardiologist, what was it? It was like, who is the last?
Great question. Yeah. So when a patient's on a blood thinner, it could be prescribed by the cardiologist, it could be prescribed by the family provider, or it could have even been punted to like a vascular clinic, like where I was working. It can go to any of those. And when you send that fax, right, if it goes to the cardiologist and it's supposed to go to the family care provider, like it just kind of goes to nowhere, right, from there. So I think it's a really good idea to find out who prescribed it last. If the patient doesn't know who prescribed their blood thinner last, you can call their pharmacy. I call pharmacies all day long. I have noticed in the last year, they are way easier to get a hold of, which has made my job a lot easier working on the insurance portion.
Sure.
So reaching out to the pharmacy, finding out who that provider is and then sending it to them because they should be able to help with that.
I thought that was a good shift in verbiage that you had of asking instead of like the cardiologist, because that's who we would assume was the one. But you said like so many times you guys would take care of them and then they go back to family practitioner and you guys would get the clearances, but you couldn't clear because you weren't overseeing. So just asking the patient who prescribed their medication for them last time, that way you can send the clearance to the correct provider. And they might not know.
You know patients, right? They're like, I don't know. I'm on Xarelto. I don't know who gave it to me. Somebody told me I need to be on this.
But at least that could be another quick thing. And then also we were talking last night about what are some other things that dentists can do when like writing scripts to help them get I think like the overarching theme of everything we discussed is one, how to help dentists have less, I think, drag through pharmacy.
Fair. Totally
I think
get it.
Because pharmacy can take a little while. And so perfect. We now know the difference between anti-quag and anti-platelet. We know which medications are probably safe. We know we can check the ADA guidelines so that way we're not having to do as many clearances. We also know if they're on a medication to find out, and we do need a clearance, who we can go to for the fastest, easiest result. And now in talking about prescriptions, you had some really interesting tips that you could share with them.
Yeah. So with writing prescriptions, right? Pharmacies are pharmacies. So I'm not going to say good thing or bad things. Right? So there are challenges working with pharmacies. I'm not going to play that down at all. If you're writing prescriptions and having issues and kickbacks from pharmacies, there's some interesting laws around making with writing prescriptions. Say that you're trying to prescribe Augmentin, 875 BID, and you tell the patient, hey, I want you to take this twice a day for 7 days, and then you put quantity of 7 because you're moving fast, right? You want it for 7 days, quantity of 7. Quantity would actually be 14, right? It's not that big of a deal. Anybody with common sense would say if you're taking a pill for twice a day for 7 days, you need 14 tablets. But law doesn't allow pharmacists to make that kind of a change. Unfortunately, they have to follow what you're saying there. So you're going to get an annoying call back that says, "Hey, you wrote for 7 tablets. I know you need 14. Is that okay?" Just delays things, right? So I really like the 2 letters QS.
That's Q as in Queen, S as in Sam.
Yeah, that stands for quantity sufficient. So you don't have to calculate the amount of any medications that you're doing. So for me as a pharmacist, when I was taking care of patients, I hated calculating the amount of insulin they would need for an entire month. So I would say Mrs. Jones needs 15 units QD daily. And then I say QS, quantity sufficient, 90-day supply, 3 refills. So the pharmacy can then go calculate how much insulin that they need. I don't have to even do that. So anytime you're prescribing anything, I like that QS personally. So that lets the pharmacy use common sense, as I like to call it, instead of giving you a call. I think that's super helpful. I
Super.
also
Yeah.
thought of one thing too,
Yeah.
going back to blood thinners, is when it's kind of like a real quick, like they're not going to have you stop the blood thinner at all. So like you're seeing if you can stop a blood thinner for a patient. There's some instances it's just not going to happen. And that's whenever they've had a clot or a stroke or a heart attack within the last 3 months. Right?
3 months.
Yeah, that's kind of like
because so many people are like,
window.
well, they had a heart thing like 6 years ago. And so I think a lot of my dentists that I worked with were like, we got to stop the blood thinners. But it sounds like it's within 3 months.
Yeah, well, I'm
most of the time. Like, and this is general broad strokes.
What I'm just trying to say is when to expect a no real quick.
Got it.
Right. So because benefits of stopping a blood thinner within those first 3 months of an event is very, very risky versus the benefit of reducing a little bit of blood coming out of the mouth, right? Like that's not
Sure.
that bad. When somebody's had a stroke or a heart attack or pulmonary embolism, a clot in the lung, like we can't replace the lung, heart, or brain very easily. We can replace blood a lot better. We've got buckets of it at most hospitals have buckets of it, right? So I'm always kind of leaning towards I'd rather replace blood than tissue at all times. So that's kind of a quick no. Is if they've had one of those events in the last 3 months, we are really, really going to watch their brain instead of getting root canal, right? Like we're really worried about them.
So you'll just say no, and could the dentist still proceed with the procedure, or would you recommend like a 3-month wait, or is it provider specific? Weigh the pros and cons because sometimes you need to get that tooth out.
Great question. I think then it's going to come into clinical. That's when you send in the clearance, right? Like, and it's great to reach out to the provider who's managing it for you. But I think it's kind of good to know exactly when you get a quick no. Quick no is going to be less than 3 months, or when it's going to be like a kind of a typical, no problem. If it's been, greater than 6 months, they're on the typical anticoagulants, Xarelto, Eliquis, nothing crazy is going on for them. You're only removing 2 teeth. This is very, very low risk. But again, I'd urge everybody to read the ADA guidelines. That way you feel more comfortable with it. I'm not as eloquent as the ADA is, right? They do a real good job. So I don't want to take any of their credit. I think they do a real good job of simplifying that and making you feel confident with providing more timely care for patients.
Which is amazing. And Jace, one last thing. I don't remember what it was. You were talking about the DEA and like 6-month rule.
Oh, yeah.
Let's just quickly talk about that and then we'll wrap just because this was such a fascinating thing for me last night.
Yeah. So when it comes to prescribing controlled substances, most providers have to have a DEA license.
Okay. First of all, though, what's your take on dentists prescribing controlled substances?
I don't think, I work now on the insurance side of things, right? And I look at the requirements which is the authorizations, the criteria a patient needs to hit in order to qualify for certain medications. A lot of times for those controlled substances, they need to have pretty significant issues going on, like fibromyalgia or cancer related pain or, end of life care, versus in all my scanning through it, I don't have a perfect picture memory.
Sure.
But I don't usually see oral pain in there. There is some post-operative pain that can be covered for those kind of medications, but I really would recommend to keep those lower. And in fact, in a lot of our criteria, it recommends, have they tried Tylenol first? Have they failed NSAIDs, or are they contraindicated with the patient? So really they should be a last line for patients.
Yeah.
In my 2 cents, but there's always going to be a caveat to the rule, right?
Of course.
Patient that comes through that has oral cancer and you're taking care of them. Like that would make sense to me.
Got it. So then back to the DEA.
Yeah. Okay.
Okay. Ready.
So as a provider, you should be checking if you're doing controlled substances, you should be checking the prescription drug monitoring program, or sometimes called the PDMP, looking to see if patients are getting controlled substances from another provider. So it's really just a check and balance to make sure that they're not going from provider to provider to getting too many narcotics and causing self-harm or harm to others. And so with checking that PDMP before prescribing, I think a lot of providers do that. A lot of softwares that I'm aware of, EMRs, electronic medical records, sometimes have links so that you can do that more quickly. However, I don't think it's as intuitive that they need to be checking that every 6 months in some states. I know like here in Nevada, you're supposed to be checking it every 6 months, not for a patient, but for your actual DEA registration to see if anybody else is prescribing underneath you. Because if you don't check that every 6 months, you could get in some serious trouble with not only DEA, but even more the Board of Pharmacy in your state. Now, I don't know all 50 states, so I check with your state to see if you need to be checking that every 6 months, but set an alarm just to check that real quickly. Keep your nose clean. I've had providers I've had to remind to do that. And if somebody was using your account prescribing narcotics, you'd never know unless you went and checked that PDMP.
Yeah, and I remember last night you're like, and if that was you, I would not
Oh,
want
I
to
would
be
not
you.
want to be
The
you.
board of pharmacy is going to be real excited to
Gosh.
find you.
Yeah.
So that was something where I was like, got it. So, and we all know I'm big on let's make it easy. And Jason,
Yeah.
I love that you love this so much, and you just brought so much value today. And
Yeah, thank
like
you.
also for me, it's just fun to podcast.
It
with
is fun, yeah.
Yeah.
Glad I got to nerd out on my world a little bit, bring it into yours. I work with dentists, or at least, when I was working in the vascular clinic, all day long. Great questions that would come through.
Yeah. So I think for all of us, like as a recap on this is number one, I think setting yourself some cadences. So maybe every quarter we check our ADA guidelines and we check our, what is it?
PDMP. Yeah.
PDMP.
So each state, so they call it prescription drug monitoring program.
Okay, that.
But there are different acronyms in different states. So that's just what it's called in Nevada. I forget what it is in California, but you can check your state's prescription monitoring program. Make sure that opioids aren't being prescribed under your name.
Got it. So we just set that as a cadence. We know 1 to 3 teeth, most likely, if they're on a blood thinner, is according to the ADA as of today, is good to go. Yep. Things that are going to get a quick no are going to be within the last 3 months of the stroke, the heart attack or the clot. I'm thinking like the pulmonary embolism, that's what we're trying to prevent.
Leg or lung,
Those are going to be quick no's. And then if we're prescribing, let's do QS. We've got quantity sufficient so that we're not getting phone calls back on those medications that we are. And then on narcotics, just being a bit more cautious. Of course, this is provider specific, and in no way, shape, or form did Jason come on here to tell you you are the clinical expert. Jason's the clinical expert on medications. And if you guys ever have questions, I know Jason, you geek out and you want to talk to people. So if anyone wants to chat shop, be sure to reach out and we'll be able to connect you in. But we've even talked about possibly, so let me know, listeners, you can email in hello@thedentallyteam.com of ask a pharmacist anything. I talked to Jason. I was like, we'll just have them send in questions and maybe get you back on the podcast or we do a webinar.
Yeah.
But
all day long.
Any last thoughts, Jason, you've got of pharmacy and dentistry as we wrap up today?
No, I think that's pretty much it. So check the ADA guidelines. I think it's really good to have cross communication between professions, right? If you're working with a pharmacy, CVS, Walgreens, or something like that, or Walmart, I know that it can be challenging, right? They're under different pressures. You're under different pressure. So I think just coming in with an understanding, not being angry at each other, you know what I mean, is super beneficial and working together. When it comes to it, every dentist that I've talked to is actually worried about their patient. Every pharmacist that I've worked with is really worried about the patient as well. So it's we're trying to accomplish the same thing, but we have different rules and our hands are bound in different ways that annoy each other, right? Like I know, Dr. Jones, you want 14 tablets, but you said 7. And I know common sense says I should give them 14, but I've got to make that change. So knowing that their hands are tied by the law, they can't use as much common sense, which is aggravating. I mean, that's why I love what I got to do here. I got to just kind of help a lot more and use common sense and improve patient care. But those kinds of things I think are really beneficial as you work together, and then not being so afraid of blood thinners, right? So I think those guidelines do a great job of giving you confidence and not worrying about the side effects. And there's a lot of things that you can do locally for bleeding. So you have a lot of control over that. I think that's pretty cool, the tools that you have.
Yeah. And at the end of the day, yes, you are the clinician. You are the one who is responsible for this. And so obviously chat, but I think collaborating, talking to other pharmacists, talking to them in your state, finding out what are the state laws, things like that, I think can be really beneficial just to give you peace of mind and confidence. And again, dentistry, we are maybe a bit more risk adverse because luckily we don't have patients.
That's good. That's a great thing.
Great.
Yeah, that's fantastic.
And so
I want my dentist to be risk adverse.
I do too. But Jason, I appreciate you being on the podcast today.
Yeah.
And for all of you listening, more confidence, more clarity, more streamlined to be able to serve and help our patients better. And if we can help you in any way or you've got more questions, reach out hello@thedentallyteam.com. And as always, thanks for listening. I'll catch you next time on the Dental A Team podcast.